Welcome to Cell Culture Community, where we explore how bioengineering can transform human and planetary health. The show is kicking off with a mini-series on neonatal health technologies, designed for use in low-resource settings. Last episode, we spoke with an engineer at Equalize Health about the design principles behind their neonatal CPAP. Today, we dive into the strategy around their phototherapy device. In conversation with Dr. Krishnakumar, who goes by KK, we explore how Equalize Health identified problems, adapted to diverse markets, drove adoption, and measured impact. We struggled a little with the sound quality on this one, but bear with us. I promise the content is worth it. KK is currently a senior advisor with Sattva, a social impact consulting firm, and prior to this, he served as managing director of Equalize Health in India, which is what we're here to dive into today. For those of you that don't know, Equalize Health is a medical technology nonprofit that believed good design can allow us to deliver high-quality medical technologies to patients around the world at affordable prices. Though they shut down due to funding challenges, over their lifetime, their devices treated 1.6 million patients in over 80 countries. And some of these devices are still on the market. So really, really inspiring work. KK, we are very excited to have you with us.
Thank you, Smriti, and thanks for having me here. And thanks also for your kind words about Equalize Health.
Yeah. So before we get into all of the questions around, global health and this kind of work, can you describe in your own words what your role was and what you spent most of your time doing?
Yeah. So my role at Equalize Health was India Managing Director. The India entity of Equalize Health had been formed in January 2020. And so the entity had to be operationalized. The team had to be expanded. The programs that the organization had in plan for India had to be implemented. So that was the role that was assigned to me to translate the plans that Equalize Health had for India into practice, and also to scale up the extent of work of Equalize Health that was happening out of India beyond what it was doing into more value-added activities around product design, manufacturing, etc.
And I'm assuming some problem areas they already had in mind, some you identified. What was the process of picking areas to work on, like at Equalize Health? Was it a very quantitative process? Did it involve a lot of field work?
Yeah, the process was, a combination of quantitative work around modeling the nature of the problem, which is an attempt to understand the nature of the problem, in terms of measures like the number of patients that could be treated, the number of disability-adjusted life years that could be impacted, etc. That was one aspect of our quantitative aspect of our approach. But there was also an assessment of the nature of the existing solutions that are there in the market and to the extent that they addressed or did not address the problem on hand. The solutions could have been anything from a low cost but low quality solution to a solution that was probably not appropriately designed, in the sense that it was designed for a Western construct or Western markets, and it did not mirror the needs of the clinical practices in India, etc. So the problems could be many, but the approach was always to start with a quantitative assessment of what we were trying to address, but also keeping in mind the nature of the solutions that existed in the market and also the preferences of users who are going to use the product, because they are an important component in ensuring that the product delivers the intended clinical benefit.
When you were trying to select a problem, was there a single metric you were optimizing for?
For us, the magnitude of the problem, right, and just ensure in terms of the number of patients or number of deaths that could be averted, or number of patients that could be saved. I think that was or has been an overriding metric, because that shows the nature of the enormity of the problem that we are up against. But it was also important for us to understand where our capabilities lie, right? Obviously, there are several challenges that the world faces, but our solution space was restricted to those that could be solved through medical technology. That was one. And secondly, problems, or even within the broad medical technology space, the solutions that fit within our technical capabilities. So these were, of course, important practical considerations for us to keep in mind as we were exploring.
KK has painted a clear picture of the filters Equalize Health applied while selecting problems: quantitative impact metrics, existing solutions, and compatibility with their technical capabilities. But I'm still curious why a large majority of their work focuses in on the maternal and neonatal health space. What were the factors that drove that? Was it the need and impact assessment? Was it kind of wanting to have a consistent story and brand associated with the company? What was driving it?
It was not so much brand, but it was the fact that that's maternal and newborn health is an area where the disparities between the developed countries and developing countries are the most significant.
Not only are the disparities most significant,
and these are not solutions where the technology is not the problem, right? It's this availability of the solutions in the market and ensuring that they are adopted and so on and so forth. So purely from the point of being able to create impact and ensure equity in health outcomes, medical technology for everyone was our motto. And of course, there is a global focus on maternal and newborn health, its association with SDGs, and so on and so forth. So there is, of course, the larger global alignment, at least in terms of thought or aspirations about the need to improve maternal and newborn.
The sheer disparity KK talks about shows up in the numbers. For instance, among extremely preterm babies, more than 90% born in low-income countries die within the first few days of life, while less than 10% are lost in similar high-income settings. I'm curious what comes up while scoping out the contours of a specific need area within neonatal health. Next, we dive into this, taking up jaundice as an example. For any of the devices that you're familiar with, the neonatal CPAP, Brilliant phototherapy device, can you paint a picture of what the final niche problem statement looked like?
I think the problem, let me take the example of the neonatal jaundice Brilliance, which was essentially a product that Equalize Health launched into the market.
Neonatal jaundice is a condition where the infant's skin turns yellow due to buildup of a pigment called bilirubin.
I think, for us, the overriding metric was number of patients who have jaundice, or number of babies who have jaundice, and how many of them receive appropriate treatment, and how many of them, could be saved from complications like retinopathy. So jaundice, as you know, is quite common in newborns. But many times it just gets better on its own. But in many cases it is not, especially with preterm babies.
Over 80% of preterm babies develop jaundice. In severe cases, pigment accumulated in the blood turns toxic. This can cause lifelong neurologic damage and be fatal. KK identifies 3 constraints that guided Equalize Health's work in this space.
the focus was more on being able to identify what are some of the considerations for developing a jaundice device which is effective. That's one. Secondly, which is simple to operate, given the fact that the product is being used in India and other low and middle income countries where the extent of training that is available to the medical professionals is not all that, is not on par with what, let's say, is available in the Western world. Thirdly, was that the product had to be low cost, not just from an initial investment standpoint, but also from a running cost standpoint. That was the third. And like everything else at Equalize Health, we also believed in market-based solutions, that the product had to be commercially viable for both the manufacturer of the product, but also for the person who was buying the product. It had to be something which was within their financial capabilities.
Within these constraints, Equalize Health decided to build a phototherapy device. Phototherapy bathes the infant's skin in bright light. This light penetrates into the blood, where it breaks down insoluble bilirubin into a water-soluble form the body can easily clear.
The products which were there on the market before Brilliance came about were about $4,000. And so that itself is a steep barrier, right? The second is these devices had 6 bulbs to provide the light, which had a life of about 2,000 hours, right? And they cost about $120, right? So it was a significant, 2,000 hours is roughly a year of use of a device. So obviously as the bulbs came to the end of their lives, the amount of light that was available to the baby reducing, and therefore the treatment was not as efficacious, etc. So when we launched the product in the market, first of all, we moved from the traditional incandescent bulbs to LEDs. The operating life of the LEDs is about 100,000 hours, right? So it's significantly higher than incandescent bulbs, could offer. Secondly, it was also blue light, not white light. The idea, again, research by Japanese physiologists had shown that blue LEDs had greater absorption, right, and therefore better ability to manage, better absorption of the bilirubin, and therefore better ability to treat. So that was the second consideration. And thirdly, we wanted to price the product at a point where it was going to be accessible to everybody. So we looked at a 90% reduction, not a 10% reduction, a 90% reduction from $4,000 to $400. Okay? So the end user price for the product was $400. Right? And therefore that addressed the affordability problem. The fact that we had the operating life of the product extended from 2,000 hours to 100,000 hours was a second win. And thirdly, the fact that blue light was more efficacious in treating jaundice than white light. That made it really an attractive proposition for the market, at least from a technical standpoint.
In engineering, we focus a lot on the cost-quality trade-off. I like this example because it challenges that paradigm. The use of long-lasting LEDs actually made this product more affordable and effective at the same time. In the next part of this conversation, we explore how this phototherapy device fit into diverse health systems and markets. I'm somewhat familiar with the tiers of the healthcare system in India. So you have primary, secondary, and tertiary clinics. And then further beyond the primary clinics, you have Asha and Anganwadi workers doing a lot of outreach. 90% cost reduction sounds phenomenal, but $400 still seems like a lot of money if I think about it from just having visited some of these places. So where in the tier system, or where in the healthcare system did this end up getting adopted, and who was paying for it? We'd love to hear a bit more about that.
No, as you know, in India at least, we have, of course, the government healthcare system, like you mentioned, has the primary healthcare centers, the district hospitals, which are essentially secondary care facilities, and then, of course, the medical colleges, which are the tertiary centers of excellence. But we also have a large private hospital system, right, where we have facilities that are anywhere from 5 beds to 500 beds in size. So the idea was that this product had to be at a price point where it could be used at any place where neonatal care was being provided, right? And in India, again, there is a shortage of neonatologists, right? And therefore, outside the major cities, most of the care for neonatology is actually provided by pediatricians. So any pediatrician who had a small facility which was going to manage preterm babies or even term babies but underweight, etc. So we wanted the product to be appealing to that large cross-section of customers. And fortunately, with the National Health Mission, which was launched in 2005.
Ever since that, KK says, there's been a conscious attempt to upgrade the facilities, infrastructure, equipment, and buildings around public healthcare.
Therefore, there was a growing opportunity for the product to be used in such facilities, but also with the private, health centers, especially in northern India, where bulk of the burden of neonatal mortality is. There, most of the healthcare was at least provided by the private sector, smaller hospitals, nursing homes, and clinics. They have different names. They all kind of indicate a small healthcare facility. The idea was that the product was going to be affordable to such customers. To make that happen, actually, we forged a partnership for manufacturing with an Indian company, Phoenix Medical Systems, based in Chennai. And Phoenix is a fairly well-known name, especially for neonatal and pediatric products. The fact that they had a good manufacturing facility and a sales team which could reach out to different customers in India also helped in ensuring that the product was available. Issues regarding after-sales service were addressed because, again, the product's kind of going to be used all the time. Right? It's not like a product where you can schedule, because the babies continuously need a few hours of therapy every day.
Yeah, I think we sometimes lose out on the importance of the private sector in delivering, and the private markets in filling a lot of these gaps. But I am curious, there will be people listening to this who are maybe coming from a point of view that more things should be made accessible for free or at lower cost, and that there should be more reliance on a government-based free rollout kind of a system. So can you make the argument for us? Why did you decide to put this on the market and go through that private system? What are the benefits of that?
Oh, I think the idea was that it was not just for the private system, though I did mention that the private system, I think the product has to work within the, health system in specific geographies. Let's say in several parts of Africa, the government is the largest provider of healthcare. And in such cases, the product has to appeal to the government healthcare system in terms of price and other, considerations in terms of reliability and so on and so forth. So I think we wanted to work within the constraints or the health systems that the product was being part of.
A lot of folks, understandably, have strong biases for or against the private sector. I personally admired how KK and his team really took the time to understand who was providing care to their target populations in different regions and cater to that.
while the private sector was certainly a focus, at least for India, we also worked to make the product available to the public health system. And that required us working with the professional associations, the Indian Academy of Pediatrics, the National Neonatology Forum, etc., professional organizations of pediatricians and neonatologists. Because we wanted to present to them the evidence that, a transition from a traditional bulb-based phototherapy device to this new one, which was LED-based, was equally efficacious, right? Because if the efficacy is not as good or if it's not better, then there's no case for change. And there is a certain switching cost, even if it's a cheaper product with the same efficacy. And therefore, we had to work with these professional associations and present to them the evidence that the product was actually better in terms of outcomes and, of course, lower, not just in terms of the initial cost, but also in terms of the running costs. And with the support from the professional associations, we were able to have these products included within the ambit of public purchases. As you know, in public purchases in India, specifications of a product, are quite important, and therefore, a line which said incandescent bulbs would have ruled us out of the tender process, and therefore we had to work within to ensure that those basic requirements of being a contender for public purchases was also addressed.
Yeah, sounds like a really intricate game of understanding all of the stakeholder priorities.
I mean, we did improvise as well. One of the things that we launched was also a light meter, right? Because to show that the quantum of light that was available on or in the field of the baby was adequate. We are not very sure how much light is coming on the baby. Secondly, there was also a requirement for a light to surround the baby. So it was almost that the baby was like a sandwich between a top layer of blue light and the bottom layer, right? So those kinds of design improvisations were also something that we had to address. And that kind of feedback about the need for having light meters, especially from Africa, it was a big requirement. All that kind of requests kind of came. But as you can imagine, the process of introduction of new features is a delicate process, keeping in mind the incremental benefits that those features provide versus the cost, the development cost, and the cost of the product itself. But I think some of these requests for change were important.
I am curious, despite taking in all this feedback and being very thoughtful, if there were any instances where you put an innovation out and it didn't really have the impact or product market fit that you had envisioned.
For example, another product that Equalize Health launched into the market was a remotion knee, and that was for people who had above knee amputations, and a loss of a limb in India and many parts of the world also means that there's a loss of ability to earn money. The limbs are an important component of individual dignity. So there, of course, there was no market, right? That's something that we realized, that we had to work with nonprofits who would then had the responsibility not just of fitting the prosthesis, but also ensuring that the tweaks that would be required to the product and, of course, the training that goes along with the use of the prosthesis, because the knee is just one component. There's a couple of other elements to the product itself, which I think while we designed the product keeping in the requirements of the Indian audience, which is, squatting and sitting cross-legged on the floor and ability to navigate staircases because they're not, ramps are not that common. So the product was designed appropriately, but our objective of scaling solutions via the market was not feasible. We had to exit that product line, and it was handed over to a company in Costa Rica.
It It was inspiring to hear how KK and his team adapted to meet the needs of diverse partners, from working with well-known pediatric manufacturers to build trust in the private sector, to medical associations that had influence over public purchasing. They even added devices such as the light meter and removed devices such as the remotion knee in response to signals from the market. Governments and manufacturers are just one type of stakeholder. Next, we talk about how Equalize Health invested in the needs of healthcare workers.
We realized that even though the devices were priced at $400, we had made sure that the design was appropriate, etc. There were still parts of India where the product was not being adopted.
By this, he means the product was bought but not used.
When we went about understanding why, we realized that many of these small facilities, especially the smaller cities of India, lacked the healthcare professionals lacked the confidence to be able to manage jaundice, right, or prematurity in general, of which jaundice could be one component. And all of them had been trained at medical school or nursing school, etc. It's just that, when you don't get to use a lot of the education that you had in practice, some of those techniques tend to fade from your memory, right? And therefore, in partnership with the University of New Mexico, we launched a program called ECHO Telementoring. ECHO stands for Extension of Community Health Outcomes. This was product agnostic. This was nothing to do with Brilliance. It had nothing to do even with neonatal jaundice. It was a program for pediatricians. It was a program for nurses, neonatal nurses or SNCO nurses, special newborn care units. It was a program for neonatologists, for pediatricians, and so on and so forth. And this was before COVID, where tele-education was really not considered an appropriate form of imparting education. But as Providence would have it, COVID came and almost every education became online. And it also helped us because, the first, I would say, few months of COVID, every doctor was essentially an intensivist, right? They were all managing COVID patients. They all had to intubate the patients. Some of them, had to learn to be able to use the ventilation. So some of these techniques that we were able to demonstrate to them helped kind of almost like a refresher training. The testimonials from the healthcare professionals, especially the nurses, and of course, seeing them, seeing the joy as they went about managing the patients, the babies. And when they come back and say, about 2 years ago, we used to refer a lot of cases to the medical college hospital. Now we have confidence of being able to manage the conditions here locally. I think those were, important, statements which kind of reaffirmed that the hypothesis that healthcare should be delivered decentralized, closer to where the patients live. Because as you know, in India, referrals are great if you have money and if you have networks. If you don't have either, referrals are really not a good pathway. Managing conditions locally without or minimizing the need for referrals through a combination of device design, commercial viability, system strengthening, training, all that I think has been, the most satisfying components of our. And all this kind of comes up in one number, 1.6 million patients or babies treated. But I think more importantly are all these qualitative success stories.
While editing this episode, it struck me that while I had heard about decentralized healthcare delivery and ASHA workers in India, I had never seen it in the context of nurses and doctors that already go through a formal training process. Doctors in well-resourced urban centers get to interact with complex cases, attend meetings and conferences that keep them on top of their game more often than not. The notion of refreshers and skill-building workshops for skilled workers in under-resourced areas is somehow radical. There's such a shortage of these workers that we don't want to challenge their technical authority or add anything more to their plate. But it sounds like KK's team was able to introduce this content in the context of empowerment and building confidence. And this, combined with their technical programming, has created immense impact. Though it may be impossible to quantify the impact of confidence building for a health worker that will treat hundreds of patients throughout their lifetime, the impact metrics Equalize Health does have are pretty impressive. I do want to take a moment to celebrate the numbers. Not only has Brilliant treated over 1 million babies, it's remarkably cost-effective. In our show notes, you can find an audit from 2017 demonstrating that Brilliance's cost per disability-adjusted life year was less than a third of the cost-effectiveness threshold based on per capita income that's generally agreed upon. I'm curious on a personal level if there was a moment which felt like a huge success, maybe some sales data came in or a launch happened.
I think that there were a few. I mean, seeing the stories of, babies who had been treated with the device, growing up to be young adults, going out and succeeding in their whatever they wanted to do in life, right? I think has always been a big motivator. I think more importantly for us, what we get to see is the satisfaction that our users, right, the health professionals get.
He says it's common for them, as a large medical device design company, to lose track of individual patients.
But the health workers, they are our link to the health system in that sense, and therefore for us to be able to show or see the joy in their eyes as they go about treating a patient or a baby or a mother, and then seeing the health outcomes, being what they are, I think has been the most gratifying.
In this last segment, we step back to understand how Equalize Health fits into the broader health technology landscape. Equalize Health is a very, very unique model, at least from the models I've come across. Doing R&D in the nonprofit sector and then interfacing with markets. There's a lot of places that research happens. You have research happening in academia. Startups are also doing a fair amount of R&D today. Do you think this kind of impactful public health-oriented work can happen in any sector, or was there something about the model Equalize Health built that really enabled you to do this work well?
Let's look at the way this concept of health for low and middle income countries, right, has been addressed so far. And probably the answers lie in that. The first approach that was given was to donate used equipment. Right? And the idea is that these are products from an earlier generation, as the hospitals in the US and other parts of the world, Western world, upgraded the products to newer technologies. Some of these stuff became, was not used, and therefore let's donate products. Right? So that was the first approach. That, of course, had its own limitations because many times the products were old and spares were not available, and the products themselves were not usable, and so on and so forth. The second approach was...
He says the second approach was to strip a device built for the Western context of its bells and whistles and call it a value product.
The product was still designed in the Western world, was designed for a Western audience or a Western health system, but it was made available to low and middle income countries at a lower price point. Again, here the challenge was that while the product may have been more contemporary in terms of design, it was not designed keeping in the patient volumes, physical environment, the skill levels, patient throughput, etc., right, of a emerging country health system, where the doctor to patient ratios or the nurse to patient ratios or patient to bed ratios are really not not comparable at all, right? So this was the dominant model. The question often is asked as to why don't large medical technology companies invest in global health. Some of them have, to be fair to them. But therefore, the answer was that these companies, the cost associated with designing and developing a product and taking it through clinical validation, vis-a-vis the returns on that product, were not commensurate.
Therefore, if the philanthropic sector could de-risk product development, private manufacturers and distributors could be presented with an attractive return on investment for the parts of the process that they are good at, which involve scaling up the product and getting it in the hands of consumers.
Because there is a fair amount of effort required even after a product is launched, right? In getting the products to manufacturing and regulatory processes, getting the products, manufactured as per quality standards, ensuring that they are, inventory is maintained, the engineers are trained on the repair and maintenance, and all that, and of course the sales and marketing expenses. So there is a fair amount of cost, but the companies, the devices companies, were prepared for. That's the part which they know well. So that is the model, and I think there is definitely a need for such a model, because the alternative could be if there are designs from startups or any other group of innovators who could provide the same kind of support or the kind of expertise in product design and development that could then be commercialized through media medtech. And unfortunately, and there's a lot of money coming into health tech. Very little of it actually comes to medtech. Right? Most of it is with health apps and so on, digital health solutions and so on.
I think it was really helpful and insightful to hear your analysis of the landscape as a whole, because you've been in the space long enough to have that bird's eye view. What's been tried, what are the constraints. We'll end on a more personal note. What's something simple you do every day for your health or the health of your neighborhood, family, community?
Yeah, I mean, I can talk about myself, what I do for myself. I think three things I would say, and these are fairly major surprises or insights here. You have an appropriate diet, right? I think that's avoid sugars and processed foods and all the kind of anything which can potentially, lead to disease of any kind. The second is to be able to do some minimal exercises. For my own self, walking is about the only exercise that I can manage. So doing that, it's not just the quantum of effort, but also the consistency of the effort. I think that's an important, consideration. And thirdly, and this is something which is not very well appreciated, especially amongst younger people, which is the need to sleep well. I guess the body requires that, we used to say 8 hours, but it's kind of conveniently come down to 6 to 7 hours now, given the lifestyles. But I think adequate sleep, both duration again and quality of sleep, I think is important for ensuring that the body gets adequate rest, so that, at body and mind, we feel rejuvenated for the next day or the next week.
I feel a little called out. I've been trying hard over my gap year to fix my sleep. Anyhow, thank you for your time, KK, and thank you, listeners, for joining us. If you like this episode, leave a rating and review wherever you get your podcast. This is a part of our launch series. Going forward, we'll bring to you every fortnight a new conversation on how technology can transform human and planetary health. Till then, breathe deep, stretch something that feels stiff, and look around. Notice something new, delightful, or in need of care. We are gifted with so many chances to love and wonder every day.